Part A, Consultation Extracts. Each extract is a conversation between a healthcare professional and a patient. Complete the healthcare professional's notes by filling in the blanks with a word or short phrase from the recording. Extract 1, questions 1 to 12. You hear a consultation with an endocrinologist. You now have 30 seconds to look at questions 1 to 12.
Good morning, Mrs. Whitmore. I'm Dr. Peterson, the endocrinologist. How are you today?
Good morning, doctor. I've been better, to be honest. That's why I'm here.
I see. Can you tell me what's been bothering you?
It's my feet, mainly. I've been having increasing numbness in both feet. It's quite concerning because I'm on my feet a lot as a teacher.
I understand. When do you notice this numbness the most?
It's definitely worse at night, especially after I've been standing all day. Sometimes it wakes me up.
And are you experiencing any other symptoms along with the numbness?
Yes, I've been having these shooting pains in my lower limbs. Sometimes it's like an electric shock going up my legs.
I see. Let's talk about your diabetes history. You have type 2 diabetes, correct?
Yes, that's right.
And when were you diagnosed?
It's been 14 years now. Time flies, doesn't it?
Indeed, it does. And what medications are you currently taking for your diabetes?
I take metformin, 1,000 milligram tablets, twice a day.
Thank you. And do you know what your most recent HbA1c level was?
Yes, I had it checked last month. It was 7.8%. My GP said that's higher than it should be.
Yes, we typically aim for below 7% for most patients with type 2 diabetes. Have you had any foot problems previously?
Yes, I had a foot ulcer on my left foot about 2 years ago. It took a while to heal, but it's completely better now.
And any other diabetes complications that you're aware of?
And my eye doctor told me I have some diabetic retinopathy. He called it mild diabetic retinopathy. I get my eyes checked every year.
That's good that you're keeping up with those appointments. Now, I'd like to examine your feet if that's okay.
Yes, of course.
Thank you. I'm going to test the sensitivity in your feet first. Can you feel this? And this?
That one, yes, but that one, not so much.
I'm noticing decreased temperature sensitivity in both feet. That's consistent with diabetic neuropathy. I also see some signs of callousing on your right heel, which we need to address before it becomes problematic.
Oh, I didn't even notice that.
Let me check your pulses. The pulse in your right foot is normal, but it's diminished in your left foot. That indicates we need to monitor your circulation carefully.
Is that serious?
It's something we need to address in our management plan. Let me also check your blood pressure. It's 145/95 mils Hg, which is elevated. We'll need to work on bringing that down as part of your overall treatment.
I thought my blood pressure was under control.
It might have been previously, but today's reading shows it's higher than the target range. Let's discuss our plan moving forward.
Extract 2, questions 13 to 24. You hear a consultation with a respiratory therapist. You now have 30 seconds to look at questions 13 to 24.
Hello, Mr. Chen. I'm Sarah Wilson, the respiratory therapist. How are you feeling today?
Hi there. Not too great, to be honest. That's why I've come in.
Can you tell me what's been bothering you?
I've been having this persistent wheezing for the past 3 weeks. It just won't go away, even with my regular medication.
I see. Have you noticed any particular pattern to when it gets worse?
Yes, it definitely worsens during exercise. Even just walking up the stairs in my apartment building leaves me wheezing badly.
And how often are you using your rescue inhaler?
I've been using it 4 times daily now. That's much more than usual for me.
Thank you for that information. Let's go through your medical history. You have asthma, is that right?
Yes, I've had it since I was a child.
Do you remember when you were first diagnosed?
I was 9 years old. I had a bad attack during a school sports day.
And have you ever been hospitalized because of your asthma?
Yes, 3 times in my life. The last time was about 4 years ago.
What are your known triggers or allergies?
I'm allergic to pollen and dust mites. They can trigger my asthma pretty quickly.
Have you had any recent illnesses that might have affected your breathing?
I had a viral infection 2 months ago. Just a cold, I thought, but my breathing hasn't been quite right since then.
That could definitely be a contributing factor. On a scale of 1 to 10, how would you rate your breathing difficulty in the mornings?
It's pretty bad in the mornings. I'd say a 7 out of 10.
And what symptoms do you experience when you're active, like climbing stairs?
I get very breathless when climbing stairs. Sometimes I have to stop halfway to catch my breath.
Is your sleep being affected by your breathing problems?
Yes, I wake up coughing quite often.
How many nights per week would you say your sleep is disturbed?
I'd say about 5 nights per week. It's really affecting my energy levels during the day.
I'd like to measure your peak flow. Can you blow into this meter as hard and fast as you can? Perfect, thank you.
How does it look?
Your reading is 380 L/min, which is below what we would expect for someone of your age and height. This confirms that your asthma is not well controlled at the moment. Let's talk about adjusting your management plan.
Part B, Workplace Extracts. Listen to 6 short workplace extracts and answer one multiple-choice question for each extract. Now you have 10 seconds to look at question 25.
So for the handover, let me update you on the patients in the medical ward. Mrs. Thompson in bed 4 needs careful monitoring today. Her latest blood work shows her glucose levels have been fluctuating significantly. They dropped to 3.2 overnight and then spiked to 11.8 this morning, despite adjusting her insulin. The doctor thinks we may need to consult endocrinology. Her kidney function is stable, and we've checked her medication chart to rule out any allergic reactions. The priority is getting her blood sugar stabilized before discharge.
Regarding Mr. Jackson's rehabilitation after his knee replacement, I'd suggest we take a measured approach. He shouldn't return to full weight-bearing activities immediately, as that could compromise his recovery, but complete bed rest isn't appropriate either at this stage. What I've outlined in his care plan is a progressive exercise regimen that gradually increases in intensity, with regular assessments every 3 days to monitor his pain levels and joint mobility. If we're careful with this approach, we should see significant improvement over the next month.
Dr. Roberts, I wanted to discuss the antibiotics you prescribed for the patient in room 215. The patient is already taking clarithromycin for another infection, and the new prescription for erythromycin could cause a significant drug interaction. Both are macrolide antibiotics, and together they can increase the risk of cardiac side effects. The dosage itself is within normal range, and we do have both medications in our formulary, but I'd recommend either switching to a different class of antibiotics or discontinuing the clarithromycin if possible.
I've reviewed the MRI of Mr. Peterson's shoulder, and the images show a partial tear of the supraspinatus tendon with significant inflammation in the surrounding tissues. There's no complete rupture that would necessitate immediate surgical intervention. I can see some age-related degeneration in the joint, which is expected for a patient in his 60s, but the primary issue is definitely the partial tear. Anti-inflammatory treatment and physical therapy would be my recommendation before considering surgical options.
Dr. Williams, I wanted to update you on Sarah's progress since the medication adjustment last week. The most notable change I've observed is that she's sleeping much better, getting about 7 hours of uninterrupted sleep compared to the fragmented 3 to 4 hours previously. Her social interaction remains limited. She still isolates herself during group activities. And while she attends the therapy sessions, her participation level hasn't increased significantly yet. The improved sleep is a positive sign, though, and might eventually lead to improvements in other areas.
All right, team, we have a trauma case arriving in approximately 5 minutes. Male, 34, motorcycle accident with multiple injuries. The paramedics report suspected internal bleeding with dropping blood pressure, so we'll need to be ready for immediate blood transfusion. He has a GCS of 14, with brief loss of consciousness at the scene but currently responsive, so neurological assessment is important, but not our primary concern. The patient is currently maintaining his own airway effectively. Let's prepare the trauma bay, with blood products ready on arrival. Any questions before they get here?
Part C, presentations and interviews. Listen to 2 recordings and answer 6 multiple-choice questions for each extract. Extract 1. You hear a presentation on advances in wound care management. You now have 90 seconds to look at questions 31 to 36.
Good afternoon, everyone, and thank you for joining this presentation on recent advances in wound care management. I'm Dr. Sofia Martinez, and I've been researching innovative wound healing technologies for the past decade. Today, I'd like to discuss how new technologies are transforming our approach to wound care, particularly for chronic wounds that have traditionally been challenging to treat. Let's begin with one of the most exciting developments: smart bandages. Unlike conventional bandages that simply cover and protect wounds, smart bandages are embedded with sensors that monitor wound conditions such as pH levels, temperature, and oxygen saturation. This provides real-time monitoring of wound healing, allowing healthcare providers to detect complications before they become visible to the naked eye. While traditional bandages still require regular changes, and smart bandages don't eliminate this need, they do allow for more informed decisions about when intervention is necessary. One significant advantage of this technology is the potential reduction in unnecessary antibiotic use. By precisely identifying when bacterial infection is present, rather than prescribing antibiotics preventatively, we can help address the growing concern of antibiotic resistance. However, the primary benefit remains the continuous monitoring capability that wasn't previously possible. Of course, implementing these new technologies comes with challenges. In my experience, patients are generally eager to try innovative treatments that might speed their recovery. The greater obstacles lie in integrating these technologies into existing healthcare systems and workflows. Many facilities have established protocols for wound care that don't easily accommodate new approaches, and staff require additional training to use these technologies effectively. While cost is certainly a factor, manufacturing expenses for some of these advanced dressings can be high. Research increasingly demonstrates their cost effectiveness when considering reduced hospitalization times and fewer complications. It's interesting to observe how our fundamental approach to chronic wound management has evolved over the years. When I began my career, the focus was primarily on the dressing materials themselves, finding the perfect covering for the wound. Now, we recognize that effective wound management requires addressing the underlying causes. For example, with diabetic foot ulcers, we're now equally focused on optimizing blood glucose control, improving vascular supply, and ensuring appropriate offloading, rather than just selecting the right dressing. This doesn't mean we've abandoned surgical interventions. They remain essential in many cases, but we now see them as part of a comprehensive approach rather than the primary solution. When we look at specific dressing technologies, hydrocolloid dressings have shown particularly promising results for diabetic patients with foot ulcers. The moist healing environment they create appears to be especially beneficial for this patient group, with studies showing accelerated healing times compared to traditional gauze dressings. While they're also useful for pressure ulcers in elderly patients and can be used on post-surgical wounds, the evidence for their efficacy is strongest in diabetic foot ulcer management. Negative pressure wound therapy, or wound vac as it's commonly known, has established itself as a specialized intervention particularly valuable for certain wound types, including deep surgical wounds and some diabetic foot ulcers. It would be an overstatement to position it as a replacement for all traditional dressing methods. It's not appropriate for every wound type, and conventional dressings remain the standard of care in many situations. Similarly, while it may help prevent complications in high-risk wounds, its primary application is therapeutic rather than preventative. Looking to the future, I believe we'll see increasing integration of digital technologies with biological treatments. Imagine smart bandages that not only monitor wound conditions, but also release growth factors, or antimicrobials, precisely when needed. This combination of digital and biological approaches holds tremendous promise. While preventative care will certainly reduce the incidence of certain types of wounds, particularly pressure ulcers, the complete elimination of chronic wounds is unlikely given our aging population and the increasing prevalence of conditions like diabetes that impair healing. And no, nurses won't be replaced by automated systems. The human element of wound care, the assessment skills, the clinical judgment, the holistic view of the patient remains irreplaceable. Technology will serve as a tool to enhance care, not replace the caregivers. In conclusion, the field of wound care is experiencing a fascinating convergence of technological innovation and improved understanding of wound healing biology. By embracing these advances while maintaining our focus on comprehensive, patient-centered care, we can significantly improve outcomes for patients with both acute and chronic wounds. Thank you for your attention. I'd be happy to take any questions.
Extract 2. Questions 37 to 42. You hear an interview about mental health support in primary care. You now have 90 seconds to look at questions 37 to 42.
Today, we're speaking with Dr. James Reynolds, a primary care physician with over 20 years of experience who has specialized in integrating mental health care into general practice. Dr. Reynolds, thank you for joining us.
Thank you for having me. It's an important topic that deserves attention.
Let's start with the basics. What would you say is the biggest challenge for primary care physicians when it comes to managing mental health conditions?
While there are several challenges, including limited training in mental health assessment and sometimes a lack of good referral options, I would say the most significant constraint is time. Mental health discussions require time to explore concerns fully, build trust, and develop a comprehensive treatment plan. The typical 10-minute, 15-minute appointment simply isn't sufficient for this. Especially when patients often present with multiple issues, this time pressure can make it challenging to address mental health effectively alongside other health concerns.
That's understandable. Given these time constraints, how can primary care physicians effectively identify mental health issues?
There's no perfect solution, but I've found using standardized screening questionnaires routinely to be valuable. Tools like the PHQ-9 for depression or the GAD-7 for anxiety can efficiently identify patients who may need further assessment. Some practices have patients complete these before appointments, saving valuable consultation time. It's also important to be alert to physical symptoms that might indicate underlying mental distress, such as unexplained pain, sleep disturbances, or fatigue. These are often the way mental health issues first present in primary care. Creating dedicated mental health appointments is ideal, but often not practical in busy settings. I try to schedule longer follow-up appointments when I identify mental health concerns during a standard visit.
Once mental health issues are identified, what's your approach to treatment, particularly for common conditions like depression?
I view medication as one component of a broader treatment approach, not necessarily the first or only intervention. While antidepressants can be extremely helpful for moderate to severe depression, they're most effective when combined with other strategies. I typically discuss lifestyle modifications like exercise and sleep hygiene, refer for psychological therapies when available, and consider medication based on symptom severity, patient preference, and previous response to treatment. It would be misleading to position medication as either the most effective first-line treatment or merely a temporary solution. The evidence suggests that combined approaches work best, and treatment should be tailored to the individual.
How has telehealth affected mental health support in primary care, particularly since the pandemic?
Telehealth has been transformative, particularly in removing barriers for certain patient groups. Young adults, people with mobility issues, and those in remote areas often find telehealth more accessible than traditional appointments. That said, it's not superior to in-person consultations in all cases. Some assessments are better done face-to-face, and some patients strongly prefer that personal connection. Rather than replacing traditional consultations, telehealth has become an additional tool that allows us to be more flexible in how we provide care. The ideal approach combines both telehealth and in-personal options, allowing care to be tailored to patient needs and preferences.
So what about more serious situations, such as managing suicidal patients? That must be particularly challenging in a primary care setting.
Yes, these situations are among the most challenging we face. My concern isn't that primary care physicians can't effectively assess suicide risk. Many are quite skilled at this with proper training. Rather, the challenge often lies in the transition between care settings. When we identify a patient at high risk and refer to emergency services or psychiatric care, that transition period can create vulnerabilities. Patients may face wait times for specialist assessment, or there may be communication gaps between providers. Creating smoother pathways between primary care and crisis services is essential. In my practice, we've developed protocols to ensure patients aren't left in limbo during these transitions, including same-day psychiatric consultations when possible and clear safety planning.
Looking at the broader picture, how do you see mental health support in primary care evolving?
The most promising development I've observed is the move toward collaborative care models, where mental health specialists work alongside primary care physicians, either physically in the same location or through structured consultation arrangements. These models allow primary care to remain the home base for most patients while providing access to specialized mental health expertise when needed. Studies consistently show better outcomes with this approach compared to traditional referral models. This doesn't mean primary care is moving away from mental health management, quite the opposite. It's about enhancing the capacity of primary care to provide quality mental health support through collaboration. And while some patients with complex needs will always require specialist care, the collaborative approach means primary care remains involved rather than completely transferring care.
Thank you, Dr. Reynolds, for sharing your insights on this important topic.
My pleasure. I hope our discussion helps highlight both the challenges and opportunities in providing mental health care within primary practice.